Hello and welcome to Talking Meds, a podcast from Prescribe, engaging conversations about medicines-related dilemmas. I'm your host, Jonathan Underhill, Medicine's Clinical Advisor here at Prescribe. Hello and welcome to the latest episode of Talking Meds. Today we're going to be talking about Genomics-informed medicines optimisation. So, as this may well be a phrase that's as unfamiliar to you as it was to me when I first heard it, we have two guests here to help explain what it is and why it's of such great importance to us all, either as healthcare professionals or as patients. So, Vicky Chaplin is the Senior Clinical Lead for the Genomics Unit at NHS England, and she oversees the multidisciplinary healthcare professional team and their associated workstreams. She's part of the Chief Pharmacist in England, David Webb's senior leadership team and the pharmacy advisory group, and they help ensure that the work is coordinated across pharmacy and medicines developments across the NHS and government within the world of genomics and use of medicines. Vicky has worked in various sectors of pharmacy in the NHS and has also worked as a medical advisor in the pharmaceutical industry. She's qualified as an independent prescriber specialising in diabetes care. I'm also joined by Paul Selby, who is a consultant pharmacist in genomics working at East Genomics. Paul has worked in several trusts over his career, but developed his interest in genomics while looking after patients with rare and inherited diseases at Addenbrooke's Hospital in Cambridge. Both Paul and Vicky have many qualifications in genomics and clinical pharmacy, etc., and it's great to have them here to give both a national and a local perspective and view of what's happening in this area. So welcome, guys. Thank you so much for joining me. Vicky, do you want to just start by telling us your career journey so far and what brought you to where you are, I guess?
Yeah, it took quite a few turns, but I like to think everything built on other parts. So I've worked in most, pretty much all sectors of pharmacy. I did my pre-reg in community, I trained in hospital, and I ended up having a really strong interest in diabetes, and I actually took that into primary care. So I did work for a CCG, and I think when I was working for the CCG, that was when I really started to get interested in the population health aspect and how that informs kind of and how we can use that to better improve individuals' health, and the tools and the levers and the data and everything that we can use. So during that period, I did a bit of work at a regional level. I did a master's in health economics because I started to get really interested in terms of how we can show value of what we were using rather than just cost. And that kind of progressed into full-time regional role. I worked in London and focused a lot on diabetes still, and started to explore, I suppose, the things we use alongside medicines, because we don't use these things in isolation, thinking about the whole patient pathway. So got a lot more involved in diagnostics, medical devices, and particularly digital. So I was really fortunate to do a national fellowship, one of the Chief Pharmaceutical Officers fellowships, and I did that at NHS Digital. And it gave me a chance I was clinical lead for the NHS Apps Library, so I was able to kind of apply the evidence, and that was when I really started to think about how do we capture the benefit of things that perhaps we haven't traditionally captured before in healthcare that aren't as straightforward as, taking outcomes out of a trial, and, how do we show that benefit for patients, and also a lot of data and trying to not just look at medicines data, but all the other data that we look at alongside it. I qualified as a prescriber, as you said, and worked in a diabetes clinic, and saw loads of complex patients where obviously that diagnosis can be for a number of reasons, and some of them are monogenic diabetes. And I think I'd always been interested in genomics my whole life. So personally, from a family perspective and being aware of genetic diseases and genetic tests, but also my work with diabetes. So when the role came up to work in genomics with NHS England, I was like, wow, this is a really great opportunity, both from a personal interest and the potential of the area, but also just, again, I suppose, bringing together all the things I was interested in, looking at how we can look at these exciting innovations, but sensibly, kind of pragmatically introduce them into the whole healthcare pathway. it's not just saying it's this wonderful thing that's going to solve everything. It's how do we use this alongside the stuff that we're already doing. So, my role kind of encompasses the informatics stuff, the clinical stuff, the workforce, the evaluation. So yeah, it's a really interesting space to be in, which will hopefully bring a lot of value to a lot of patients.
Brilliant. Thanks, Vicky. Paul?
So I've been in hospital and secondary care for my entire career as a pharmacist. I have been really lucky to have experience sort of across all the specialities and all the work that goes on in those acute trusts. But really, I would say my career sort of slowly started to kick off when I was appointed to post at Admiral's Hospital in Cambridge. And that really got me to focus on looking after patients with medical conditions. And as part of that, there was this group of patients who had rare inherited metabolic disorders. What really stuck out for me at that point was how me as a pharmacist, how I could impact the way we use their medicines, how we could make their therapy and their treatment better. Even though it's quite a specialist area, it was sort of crying out for a bit of support at the time. So I took some of that learning, being involved in some national work around those conditions, and took those sort of thoughts and applied it to the other area of work that I was doing a lot of at the time, which was patients with liver disease, and have tried to sort of progress that in a national sense as well. So I became an independent prescriber in renal disease, but then translated that across to help with the hepatitis C quality improvement program, and heavily involved in how we implemented that program and treated patients for hepatitis C with new direct-acting antivirals in the east of England, and used that as a sort of kicker on to expand some other aspects of my portfolio. So I'm now a clinical lecturer at the University of East Anglia, supporting their postgraduate module on liver disease and public health. And I was involved in establishing the British Hepatology Pharmacy Group and the Genomics Specialist Interest Group at UKCPA. So really just trying to use some of those experiences to elevate that, and really just trying to make sure that we've got excellent opportunities to get our colleagues to support patients really with their medicines to get the most out of their therapies, and even the little things like making sure they've got access to the medicines they need at the time they need it. Really, really important, really impactful. And that's what I've learned from my career more than anything else.
Yeah, brilliant. Thank you both. I think that it'd be really interesting to explore the relationship between what happens at a national level and then what happens at a local level later on. But I think that gives us a really good picture of both your career journeys and why you're passionate and interested in this quite exciting and innovative sort of arm of pharmacy and medicines, really. So, to that end, as I said before, I really like the term genomics-informed decision-making. This is something that Vicky sent an email to me yesterday and said, this is the terminology we're using now, which made me think back to part of my career when I was working at the National Prescribing Centre with Professor Neil Maskery, and we were struggling with the concepts around evidence-based medicine and how it didn't convey the uncertainties that we have around the use of evidence when making decisions with our patients. And we came up with the term evidence-informed decision-making, along with a guy called Geert van der Heerden from Holland. And when Vicky emailed me yesterday, I thought, oh, crikey, that reminds me of that discussion that we had. So I wonder if that's where this came from, Vicky, that sort of, to try and get that, the concept of this is using genomics to inform our decision-making and to optimize medicines, not, as some people think it is, here's the genetic profile of the person, and we know that if they take this medicine, it's going to fix them, and if they take and it's not going to give them any side effects because they've got this potential gene profile. It's not like that, is it? So that sort of that uncertainty is really helpful in the terminology, I think.
Yeah, no, I think that's fair. I mean, genomics informed medicines optimization, I think there's a few reasons. It covers a huge breadth, but I think, as I was, I suppose, alluding to before, I think whenever a new innovation comes, and I mean, genetics isn't new, but I guess it's gaining more use. People are always like, oh, this is brilliant, but it's really important to keep sight of the stuff that you already do, And yes, obviously the genetic individual of a patient is, some of the most personalized individual information that you can have, but we still already make decisions based on all aspects of patient information, and there may be things about their current health, environment, and all those factors need to be considered. Truly personalized medicine, which is what we're aiming for, covers as many aspects of the patient and what's important to them as well, which you can't really capture from their genetic information when you're making that decision. So, it's incredibly exciting now to have access to genetic testing to help inform the use of medicines, but that's what it does. It informs the use. There are lots of other, pieces of information that we still need to consider, that everyone still, does as part of their day-to-day, as part of that shared decision making with the patient. They need to use all those pieces of information. Genomics is a really great complementary piece of information, but it is not the only piece when you are thinking about treatment decisions for patients. And I guess just the other aspect of it as well is just to, I suppose, show the breadth of how genomics can inform medicine's use. So I think, lots of people think about pharmacogenomics, and I mean, there are semantics associated with the terms and people can debate them. But essentially, we've got kind of a whole spectrum of how genetics can inform medicines, from how it influences how we respond, whether kind of how effective it is or whether it sets off our immune response, to actually looking at precision medicines, using targeted medicines that have been designed, in terms of specific genetic alterations. So I think, and then we go all the way to the other end of the spectrum with kind of gene therapies. There's such a huge breadth. Genetics will pop up everywhere, and there is a quote in the 10-year plan which talks about how genomics will inform 50% of healthcare interventions by 2035. Well, probably quite a few of those will be to do with medicines, because medicines are everywhere in the healthcare system.
Yeah, you can't get away from medicines, can you, at all? So yes, medicines obviously feature large in the 10-year plan. And when we discussed this with Laura Angus last year, I think the term genomics came up, I think it was 118 times or something within the 10-year plan. So
I think it's 119, but yes,
yeah, okay, there we go. But it's a lot, isn't it? So there's obviously a big emphasis being put on that from a policy level. So just to go back to the basics then, for somebody like me who doesn't really have a good understanding about what we're talking about here, not really. Vicky, what are the key principles here involved in genomics-informed medicines optimization, pharmacogenomics, those sorts of things?
I suppose the key principles is that everyone has a genetic profile, which we're now obviously starting to get more and more information about, and there will be specific alterations in genes that may affect either how we respond to medicines or involved in certain conditions where we can use medicines to target those. So the principle is that information can really help inform us in terms of which medicines are best, which ones should be avoided, as in another part of the decision making in terms of what is the best option for that individual patient, as I've said, alongside all the other information. But it's a really useful key information that perhaps wouldn't be quite as obvious. You can't look at a patient and say, oh, do you know what, I think you've got this specific genetic alteration on one of your CYP genes, and therefore you're not going to metabolize this medicine as well. So I think that's an important part of it. But I guess the other aspect that I like to get across is that actually this isn't as alien or as strange to healthcare professionals as perhaps it sounds when we use genomics. And it sounds, we all know what the HLA system is, and how our immune system can react to things. We know that CYP enzymes metabolize an awful lot of medicines. We know that certain diseases are due to changes in genes and various other things. This is just about applying that knowledge and using a test result that comes directly from the genome, rather than, perhaps before we were looking at kind of markers further down the line or other tests. This is just another piece of information, but it's still talking about that whole mechanism that we're all familiar with. It's just a different way of looking at it.
Yeah, that's really helpful. So, I mean, as part of shared decision making and person-centered care, having some genomic information or genetic information would be pertinent to that decision for that individual, wouldn't it? But as you say, the other principles still apply. What is it that matters to you here, being the most important one? And we talk about that all the time on this podcast. If you haven't had that conversation, haven't asked that question of the person, then you're unlikely to be able to do the best for them. Just following a guideline by rote, and just applying, say, someone with heart failure and saying, well, you need to be on these four medicines. You have to be on these four medicines. No, it's not quite like that. It's about taking into account what's important to that individual, but also perhaps the information that's pertinent to that individual as well, such as their gene profile. So in terms of how this works then from a sort of a national point of view, and we'll come back to Paul in a minute for his view on how it works locally. So obviously you have a national role, Vicky. There is obviously some policy here that's really important. And I would have thought there'd be a structure to the networks that you help serve as well. So how does that work at a national level then?
So genetic testing whole is a nationally commissioned service. So which is part of the reason for kind of the department that I work in. So genetic testing is delivered in the NHS via the NHS Genomic Medicine Service. And in order to enable that delivery at a local level, we have 7 regions across England. And within those regions, they have genetic laboratory hubs who provide that expertise around the testing. But we also have they're currently called Genomic Medicine Service Alliances, but they're kind of from April 2026, we'll be looking at it more as one region. But that's where that kind of local clinical expertise, how do we deliver it to patients, things like such as what Paul's role delivers is absolutely essential in order getting this out there. So, from a national level, yes, we look at tests that should be delivered, and that's great because it means if it's commissioned nationally, it's commissioned for everyone. Everyone can access it. But obviously, as we know, there are nuances, different needs, different aspects in terms of actual delivery, which is why it's so important to have those regions kind of leading on the delivery of that care within the genomic medicine service. So yes, we have, and we all work extremely closely together. We're quite fortunate, I think, in that respect, is that the national aspect of it is very closely tied in with the region. There's a huge amount of expertise there. So while we're evaluating what needs to be delivered nationally, we're getting that active feedback all the time from our genomic regions, who are in turn, our main point of talking to and working with healthcare system. Because at the end of the day, if this doesn't integrate into day-to-day care, we're not trying to a separate industry here. We have clinical genomic services. We shouldn't confuse that with those. They're still incredibly important, very specialist genetic services. But when we're talking about, genomics informing medicines use, is to be delivered as part of your standard pathway. You don't need your patient going off and having a whole separate pathway just to find out that information. It needs to be delivered to them at the normal point of care where they're used to having that, so that information can be provided alongside everything else for that holistic decision making. So yeah, that integration with the rest of the healthcare system is essential, really.
Yeah, no, that's really helpful. So from your point of view, Paul, how does it work locally in your trust, or indeed with the networks that you have?
Yes, so I'm based regionally across the East Midlands and the East of England. So there's 7 of the Genomic Medicine Service Alliances in the country. So I'm just covered one of those, and I'm in a job share arrangement at the moment. So with my colleague, we cover that patch. And for me, it's really about taking the work that we can in terms of the genomics labs and all that we're doing more sort of that's nationally commissioned, and making sure that we've got the steps in place, we've got everyone ready to use those tests appropriately. So we do quite a lot of work in terms of making sure we've got clear guidelines, clear pathways. We've done a small amount of audit work in the past to make sure that we are using the tests that are available to us. And yes, we have networks. So I work quite hard to make sure that we've got a network within the region. And that's really useful because, as you can imagine, relationships are so important to moving anything forward, particularly when you're trying to innovate or you're trying to implement something that's a little bit uncommon. And so, so it's really about creating and identifying the pockets where we can get early intervention, and also the pockets where we might have a bit more resistance or a bit more struggle, to make sure that we got the support across our region for all the patients that we need to support in the implementation of pharmacogenomic testing, or genomics-informed medicines optimization, I should say. So, yeah, as I said, it's really about providing support, providing those networks, and we work quite closely to build those relationships to allow us to do that. The one example I would say is that by having those networks, we've been able to bring some of our GP practices in the region in line with one of the studies that was going on, and support them to be part of that. So that made sure that we really got our region, and we get sort of national representation within a study, and it doesn't get restricted. So that wouldn't have been possible without having these rules and having that job in place.
Yeah, interesting. So how many people are there like you then, Paul, in across England? Pharmacists working in sort of at a regional, local level.
So it's really variable. So there's a pharmacy lead for each of the GMSAs, so that's 7. And then within each of the GMSAs, some of them have got pharmacists or pharmacy technicians working with them to help support that implementation. So I would say you could count it on your fingers and your toes probably, and you'd be about there. But certainly there's a lot of people doing more work than that from interest, and where people are doing the work, a lot of it is bits and pieces here and there, and it's sort of supplement a job rather than being full-time. So we're quite limited, but I think one of the things we are pushing, promoting, is that pharmacy teams, where they've got specialist members, should also be leading on this. So, for example, if you are a consultant pharmacist in a specific area where you've got genomics-informed medicines optimizations, we would also look to them for leadership. And actually, our job there is to support those pharmacists to have the skills, understand what's being asked of them, so that when they do provide the leadership in those areas, we're represented and genomics is considered.
Brilliant. No, I like that. And you also mentioned as well the networks that you've got as well. So there's the UK CPA genomics group, isn't there? So I guess for listeners, if they want to get involved in this, is that something that people can sign up to, or do you have to be working in this field before you can show an interest in that?
Definitely don't need to be working in the field before you show an interest. Genomics and pharmacogenomics will have a massive impact across a whole swathe of things. I would say that there are other opportunities other than just UK CPA. It's a great opportunity. There's been national webinars. There's, I think, script webinars coming up soon, hopefully, which are areas to start to get involved and get in touch. But if you get a chance to catch the name of one of your pharmacy leads, there's going to be a network in your region. And we're looking at the moment at how we can kick those on and really support staff working day to day in difficult situations. What can we do to support them to upskill their knowledge and get ready for this, but also be ready so that when we see positive appraisals, positive decisions, we can really just focus in on implementing them as to get the benefit as soon as possible.
Brilliant. No, that's really helpful. We'll put some links in the show notes to these groups so people can find out more. You mentioned the upcoming webinars that Prescriber are hosting on pharmacogenomics, or genomics-informed medicines optimization, that I think we're going to call them now. So for people interested, again, we'll put the links in the show notes here, but the first one is on Tuesday, the 21st of April. And then we've got another 2 subsequently after that in May and June. So, and again, we'll put the links in the show notes for those. So just in terms of, so we'll talk about the general principles then. I guess people might be interested in some of the examples that are impacting on clinical care now. So Paul, can I come back to you? What are the things that are likely to be impacting on clinical care now from a sort of a genomics and medicines perspective? And I'm thinking about the stuff that NICE have looked at. So there's clopidogrel and 5FU that I can think of off the top of my head, but I'm sure there are others.
Yeah, so those are great examples, and actually I would just challenge us to take just a step back on that. We mentioned before, and Vicky mentioned at the beginning, about genomics-informed decision-making. And so actually a lot of the work that we do in genomics is around things like targeted cancer therapies. So we have huge portfolios, which we don't have time to discuss, around rare diseases and cancer. And by identifying variation in the tumor cells or variation in an individual's genetics, we can then actually attribute different treatments to that. So that's really, really powerful. It's really important. I think it's very important that we don't lose sight that we've made significant advancements in the way that we can treat cancer by using those targeted therapies.
Absolutely.
The other example that I think is a really, really good sort of gold-plated, gold standard example related to that is where we do testing in a gene called DPYD. It's really powerful because this is the 5-fluorouracil or capecitabine, the predominant drugs that we use. They're metabolized by this enzyme, dihydropyrimidine dehydrogenase, and there's around 3 to 9% of people in the UK who carry this variation in the gene, and that would result in diminished function. And so by understanding that, we can then recommend some dosing adjustments for those patients, which can then reduce the incidence of adverse effects while still providing effective treatment. So really good example because it's so impactful to patients. It's really clear on how the variation in the individual can be used to make a dosing suggestion, can be used to benefit them specifically. So, in many ways, we talk about that being our sort of gold standard, and it would be remiss not to mention it. I think you mentioned clopidogrel, and we've obviously had the nice health technology assessment, which is ongoing, and we're just looking at how we implement that. It's been in literature for many years and could really be significant in terms of the fact that clopidogrel is a prodrug and therefore needs to be metabolized in order to get to the active constituent. It means that if you lack the enzyme to metabolize that, you're at the potential for not getting a benefit from clopidogrel. Again, as we said at the top of the podcast, it's not quite as clear cut as that necessarily. The evidence doesn't play out perfectly, but it's pretty strong correlation. Because of that sort of imperfect correlation, I think some of the implementation needs to just be really carefully considered, particularly in how we do it, and other risk factors affecting whether the patient would either respond to clopidogrel or also, we're talking about reducing risk of recurrent strokes or recurrent heart attacks, and therefore there are other factors that we can modify to affect that. So that's not really quite impacting on clinical care now, but will hopefully be one that we look to in the future. We do have a small number of tests that are on our test directory. They are, for example, there's a drug called fibromycaptopurin, which is used for patients who have acute lymphoblastic leukemia. And so we do offer testing in TPMT and NUDT15 genes for that. And there is a limited amount of testing for some patients to identify variation in mitochondria, which might affect their risk of developing hearing loss secondary to aminoglycoside antibiotics.
Yeah, so it's interesting talking about the clopidogrel guidance from NICE, and there was an implementation guide that was published alongside that, wasn't there, Vicky?
So so I think people have probably been following the updates on the NICE guidance probably since it was published or before. And I think they would have seen on there about how we were working on implementation. And I think that was because, this was simply the biggest potential genetic test that we would ever have delivered for a single indication, and that's the thing about genomics-informed medicines optimization, is it takes the traditional genetic testing, small targeted population and turns it on its head. We're talking large volume, quick turnarounds, delivering it as part of mainstream care. So we knew there was an awful lot that we needed to understand, and we were getting that feedback from stroke centres as well, going, how do we do this? We don't know how to do this. So we have a pharmacogenomics and medicines optimization network of excellence who are there to give us that information on how do we implement stuff, because it's not just as simple as providing a test. So we commissioned them to do an implementation pilot around the NICE guidance, and they worked with a few sites 3 doing lab testing, 1 doing point of care testing. And it was, extremely helpful in terms of the feedback that we got from them. The National Stroke Programme worked with us as well. And it was just really understanding, what does it mean to deliver this test in practice? What are the challenges, and anyone who looks at that implementation guide will see a lot of the themes, I think, that come up, which is not just the test. The people were saying, is it about talking to a patient about the test? No, most of them were perfectly fine with having the test. They didn't have any concerns necessarily. And, they had patient information, things like that. It was things like, where do you store the result? What's the informatics system? How do I get the result between here and there? Is the turnaround time? So some really, really useful learning. We're seeing some other important things coming out, like the first ever UK PGX CERSI guideline. So CERSI stands for Centre for Excellence in Regulatory Science and Innovation. So it's something that is, again, we were talking earlier about how a genetic test isn't everything. If you can't have clopidogrel, what medicine do you have? Because all of those medicines have various risks and benefits. There's bleeding risk, there's all these other things you have to weigh up for the individual patient. So that guidance that came out very recently, the CERSI guidance for clopidogrel and CYP2C19, is just another tool that we will have in the future to support implementation when we get to that stage. So I think it's really helpful to have those things in there, thinking about what education and training we need for our staff, guidelines, logistics, informatics.
Yeah, that's brilliant. I mean, for me, it's like, if I was a early career pharmacist, and I wish I was, but I'm not anymore, or even somebody who's looking for a new challenge, I'd be putting this in my CPD portfolio. I'd be putting it into my objectives for next year, and I'd be seeking out, if I wasn't sure about this, I'd be looking to educate myself on this. I'd be looking to potentially look at opportunities around this area, because it does sound quite innovative and exciting. I don't think this is going to go away. I suspect this is going to be with us certainly for the rest of my career, and I suspect for generations to come. So it's a bit like, if you haven't done your independent prescribing qualification and you're an early career pharmacist, you probably want to be doing your IP, don't you? And likewise, you want to be putting something in your portfolio about genomics-informed medicines optimization as well. So thank you both very much for that really good overview of the generality of this. As I said, we're going to come back with another episode where we're going to go into a bit more detail about some of the specifics, around the differences between point of care tests and lab-based ones, some of the evidence around this, the emerging evidence, etc. So thanks both very much for this, and we'll see you again soon. We hope you enjoyed today's podcast, and we'll see you in a couple of weeks for the next episode of Talking Meds from Prescrip, engaging conversations about medicines-related dilemmas. Please follow us on LinkedIn and Blue Sky to join in with the discussions, and email us on talkingmeds@prescrip.info with your feedback or suggestions for future topics or guests. Please don't forget to register for access to the Prescrip website for all of our excellent resources.